Hi, my name is Alejandra Cardona Del Valle. I'm a PGY1 doing currently my transitional year. I started on emergency medicine. And my presentation is going to be about ovarian masses. I am currently trying to do a RSNA case report on an ovarian mass that on the imaging center of my family, I kind of followed that patient and I found it really interesting. And I just wanted to talk about it. So starting about talking about a little about this benign ovarian masses or malignant ones. The benign ones are more common, fortunately. You can have functional cysts. You can see functional cysts either by follicular or the corpus luteum, which is normal on a reproductive woman that in the time of her ovulation, you can see these Graafian follicles or corpus luteum getting really, really big, and they may be painful at times, but they mostly resolve on themselves. So treatment is just observe them. Benign tumors like the benign cystic teratomas, they are also called dermoid cysts because although all of the three germ cell layers are there, they consist mainly of ectodermal tissue. Fibromas, it's also another common finding on women, which is a slow-growing connective tissue on the uterus, and cystoadenomas, which they can be either composed by serous or mucinous components, and they are fairly benign. They can be taken out if they get really, really big and cause symptoms to the patient, or they just wait and watch for them. For the malignant ovarian tumors, well, you have to look at which layer it came from. If it comes from the epithelial one, this is derived from the cells on the surface of the ovary. This is the most common one, and it occurs primarily in adults. The germ cell layer one, it's derived from the egg-producing cells within the body of the ovary, and it occurs primarily on children and young adults. And these years are important to actually try to differentiate which kind of tumor you're seeing on a woman. And the germ cell are more rare in comparison to the epithelial ones. The stromal wars are even rarer, and this class of tumors often produce even steroid hormones. So we can see here where they are arising from. So the stroma, it's here, which is like the rarest kind of malignant tumor. The germinal ones are fairly 10 to 15%, and the most common one is the epithelial cell tumor, malignant transformation. So it is important to, whenever talking about this kind of tumors, or if an imaging finding you see an ovarian mass, that you know how to differentiate, well, for every tumor, of course, if it's benign or malignant. So the benign ones will be small, slow-growing, non-invasive, of course, well-differentiated. They do stay localized, right? They don't go anywhere, so they don't metastasize. In contrast with the malignant ones, which they are very large, very fast-growing, invasive, poorly differentiated. This is very, very important, and they do like to go everywhere. I know vascularization is not here because it's, even if you don't see the vascularization, you cannot discard the reason that they can be malignant, right? So vascularization, it is helpful because some of these tumors like to go everywhere through the blood vessels. So it is helpful, but I know it's not there on the differentiations. So yeah, this is always important to take into consideration, not only for ovarian masses, of course, but for every kind of tumor. So what I did is I put two cases. One of them is the actual one that I kind of followed the patient through it, and I found it very interesting. The other one was like a bonus because when I was doing the other case report, my mom was like, oh, there's another ovarian mass that you should look up. And yeah, I kind of added to this presentation. So the case one is a 22-year-old female complaining of painful periods for 2 months. She was having she always has regular periods. It's just that 2 months, they became increasingly worse in terms of pain, just the pain. Menarche at 12 years, and her last menstrual period was in March. And I did a pelvic examination on her, and I did felt something on her right adnexa, like a pulp of a right mass. It was solid. And then a pelvic ultrasound was ordered by her OBGYN, and we performed it at the imaging center on April 12th. And this for the findings. So starting with the uterus, we did a pelvic ultrasound on her, as I said, and this is the uterus. One of the things, it was retroverted. I find that interesting. Of course, I'm learning. So I find a Google pic that actually tells you how, that actually tells you how the anteverted will be like the most common finding of the uterus, that it's pointed, the fundus is pointing to the bladder. And then the retroverted, it's pointing away from the bladder. So hers was pointing away. So of course, retroverted uterus, but it was normal in size, nothing major there. Then we moved to the left ovary, which is here, and the measurements were okay, 2.1 by 1.8 by 1.9, with two little follicles that we can see as here as well. Remember how I talk about like those benign ovarian masses? So follicles are there, but I mean, these are rather small. The largest one was measuring like 6 millimeters, and even on color Doppler, I know that this seems like a lot of color Doppler, but the ovary is here, and everything was normal there. But then when we look at the right ovary, there's this big cystic lesion that it's taking the whole ovary, right? It's measuring roughly 9.3 by 9.8 by 8.9. And so this is a complex cyst with this soft tissue here that is seen. And when we do the color Doppler, the peripheral vascularity is mildly increased, and it's also pushing on the bladder. So you can see here how the bladder, it's doing like a mass effect there as well, and the uterus. So she went for her OBGYN visit appointment. She went with the results, and her doctor ordered her a CT abdominal pelvic with contrast, and we performed that on April 15. And these were our findings. So we found this big mass, of course, that we already know it was there. It was mostly composed of like fat, and obviously this is fluid, right? But then there was like a little calcification there as well. So a complex mass with like a bunch of tissue, different tissues, right, going on there. So yes, this one is post-void. So we told her to go pee, because that would help us differentiate the mass better, right? And here are the coronal views. She was very thin, so it was really easy to pick up all the organs. I love this image, and you can see here this right ovary mass right on top of the bladder. And here is the sagittal view as well. We can see that it is doing a very big mass effect. I don't know, she wasn't having any other symptoms. She wasn't even in pain. She was walking okay. And I can only imagine how, I mean, that big mass there, right? So the radiology report at the level of the right adnexa, 11.7 by 8.4 centimeter mass containing fluid, fat, and even calcium. So a dermoid was favored, because you know how I talk about all these different layers. So they were all there. So fat, fluid, even calcium, and a malignant transformation cannot be excluded, because they don't tend to do it, but it can happen. So what was the next best thing? So a surgery consult, take that thing out. I mean, that doesn't belong there. It can be bad for her, right? It can become malignant. So she went to a surgery consult, and they prepared her for surgery on June 24. And I do have the pictures of the gross of the thing that they took out, right? The mass. So here they are. This is very big. When they open it, it was mostly composed of fluid, but it was also containing fat as well, right? And this little, I know that it's difficult to actually pick it up from an image, but they told me that these ones were really, really hard, like calcifications, right? I know that we think of teratoma and like hair, teeth composed, right? The masses. So one of these could be the teeth components. So yeah, fat and all the fluid in there. They do the pathology, and the pathology came back. Unfortunately, it came back as grade 3, which I didn't know. This kind of masses, you know, they are graded in terms of differentiation. So if it was a grade 1, it was good in terms of how differentiated was the tumor. So grade 1 tumor limited to ovaries, it's just limited there. It's partly fair differentiated, so not so bad. And then type 3, which is here, which was hers, it was involved with one or both ovaries or fallopian tubes or primary peritoneal cancer. So they also did the peritoneal lavage and everything, and the peritoneum fluid was negative, fortunately. But I think she's scheduled for Friday to actually talk with an oncologist now and see how they are going to further work that up, even with like either with chemotherapy and radiation, at least for 6 months, because this one is really invasive and it's really dangerous. Another thing that was bonus for her was her pre-op chest x-ray, which of course she did it at the imaging center. I saw that picture and the radiologist was like, okay, just see the pictures, just see the chest x-ray of this patient. I was like, oh my gosh, she has something else? No way. At first I was like, okay, I see like the lungs are clear, nothing major strikes. But then when we were talking about the right border of the heart, I was like, is there something there? Because I cannot pick up the right border. And also how the posterior ribs are more horizontally than, you know, normally that they are more diagonally. So yeah, those were the major findings there, because she also has the anatomical variation of pectus excavatum, which, I mean, patients are asymptomatic with this one fairly all the time. If they do develop symptoms, it would be like shortness of breath and stuff like that. But yeah, this was interesting because I was like, oh my God, another thing with her. The radiologist said on the report, mild displacement of the left heart border into the lateral aspects of the left hemithorax, and the right heart border is not well seen, probably due to pectus excavatum. So a lateral view is recommended for correlation. This is not her, but here, of course, on the lateral view, we can see that chest deformity more pronounced. And this is what an actual person with pectus excavatum will look like. The contrast of that will be pectus excavatum, which is pointing outward. So yes, that was bonus for her. And on her CT, then I searched for it, and I saw the deformity right there. So yeah, it looks like a heart shape. And this is the normal a normal CT scan where you would see that thoracic cavity very well rounded, but here you would see the pectus excavatum. So for my case 2, it was a 61-year-old female complaining of pelvic pain. She had this history of unspecified ovarian cysts and uterine fibroids. Her last menstrual period was when she was 53 years old. So she did have a history of irregular menstrual periods. She had 2 pregnancies, were live births, and everything was okay there. A remarkable physical examination. I did not find anything very specific for her, and transvaginal ultrasound was ordered here. So it wasn't pelvic, it was transvaginal. And it was done on April 14, 2021. So again, try to ignore this. I'm gonna talk about this. I know it's like very striking, but talking about the uterus, it was an endovaginal one. So how to tell if it's anteverted versus retroverted, it's kind of the same, but on the endovaginal one, you go through the vagina. So the uterus is more well seen. And here you can see the fundus pointing upwards, in contrast with here that it seems kind of the other way. So it seems kind of reversed. So that would be retroverted. And this is how her uterus was shown. So bladder was here retroverted. Also, another finding on the uterus will be this little calcification. So a calcified fibroid was there in the anterior wall of the uterus. She had some other fibroids as well. And when they put Doppler there, nothing striking light up. So yeah, there's a calcification there, probably a fibroid. And then right ovary here, measuring, okay, 1.8 by 1.4 by 1.6 centimeters. And when they put the color Doppler, no increased vascularity seen, so everything was okay there. But then the left ovary, so left ovary was fairly replaced by this 7.8 by 5.6 centimeter cyst with several thick septations. So they do the color Doppler and again, mildly increased vascularity. And this soft tissue, formation of a soft tissue nodule in the wall of the cyst was striking as well. So again, malignant transformation cannot be excluded. Follow-up exam is recommended. So her OBGYN actually ordered an MRI for her. MRI pelvis with contrast and without was ordered, and it was done on June 29. And these were the findings. So the uterus, it's right here. It's measuring 9.2 by 4.2 by 6.0 centimeters. And the meodometrium is mildly heterogeneous with at least 4 fibroids. I did show some of them here, and also this one. The largest one was measuring 20 millimeters. But yeah, this is her uterus. These were transverse T1 with spear, which is the fat saturation sequence. And then I did not get a good image of the right ovary, I'm sorry, but the right ovary was measuring okay, 2.0 by 1.6 by 1.7, and it was within normal limits. But the left ovary, which is here on T1 and then T1 spear without contrast, it does have a predominantly cystic mass with hemorrhagic mural component. Underlying malignancy cannot be excluded. So yeah, we can see here that it's kind of right, because I know hemorrhages on MRI, even if it's T1, if they are subacute or acute, they can present right. And then these are the other findings for her. Again, this is the big cystic mass with T1. This was with contrast, so we see the uterus, it's getting brighter. It did kind of enhance like the whole, the whole border of the mass. And on T2, of course, everything is cystic, so it's gonna be all bright. But you can see how different, like maybe some like different components there as well. And these were the coronal views. This doesn't have, these do not have fast saturation. That's why it's so bright, because she was obese. But T2 coronal, we can see here the mass and all these like kind of different fluid components there. And the T1, which, okay, you see how the different fluid levels will be here in terms of how like the septations are there as well inside of the mass. And T2 spare sagittal view as well, just to see and compare the bladders here, and just to see how it would look on a sagittal view as well. Very interesting for me, seeing two masses on different ages, right? So what will happen to this lady? Probably it's surgery consult to either perform, take that ovary out, or a total hysterectomy. She's post-reproductive. She's also having fibroids on her uterus, which may be causing some pelvic pain. They are not fairly big, but they are getting calcified. And then if they take all of that, maybe some hormone replacement therapy and close observation, and they have to know about the pathology. Unfortunately, this lady hasn't gone to the doctor afterwards, so I have to call her and tell her, yeah, you better go to the doctor, and just to see what pathology says. And yeah, I think it's interesting to also follow this case. In conclusion, adnexal masses present a special diagnostic challenge. They are usually benign, but it's always important to differentiate them, because on that first case, the 22-year-old, where she was having like no striking symptoms whatsoever, it was a grade 3, right? So it is important to differentiate them and pick them up as soon as possible. Ultrasound is the most practical modality for assessment of ovarian tumors. I love ultrasound. It's very easy, very cheap, of course, and very fast. So it will give you like a fast screen of that patient. So it's very useful. Things to look, of course, you would look for like non-fatty solid vascularized tissue. Even if it's not vascularized, you have to think about malignant transformation with thick septations and papillary projections. Color Doppler, of course, help us with this vascularization components in a mass. CT can help assess the extent of the disease in patients before and after surgery. So I think that's why the first case was actually ordered a CT, because they already know the mass was there and it was fairly big. So they just had to characterize where exactly was it and which organs were, compressing. So the surgeon could guide his surgery better. Because MRI will give you more information about what is the composition of that tumor. So material cystic teratomas, cysts, endometriomas, leiomyomas, fibromas, and other lesions can be accurately diagnosed on the basis of those T1, T2 weighted and fat saturation sequences. So MRI better for description, because and for like soft tissue, they are very specific, the MRIs, more than CT, where like little masses can be missed on that one. These are my references, and that's about it.